So we move on to Dr. Rohit Prakash. He would be talking on RCA, root cause analysis of mistakes during phacoemulsification.
Yeah, thank you, Dr. Tushe. So this is the case 1, which is a routine cataract, and the patient has nucleus sclerosis grade 1. The pupil size is 6.5. The biometry shows that there's no extreme length of the eye in any case. The resident started the surgery. So in this case, you will find that she's doing hydrodissection in a very slow manner. Everything for her, is being done in a very cautious way. So she starts the surgery, and while doing the surgery, she's going on, and suddenly she realized that there's a punch. Now what next, Dr. Gaurav? How would you, go about it?
So first thing is you have to suspect that there's been a PC break over there. And, if you do wishful thinking and you think that, I should have got away. So I think you should pause, don't switch off the infusion. Keep your infusion on and then start thinking whether, maybe zoom in and see if there is you can see something broken there. If you can't, then I would actually suggest that, keeping the infusion on, go and inject viscoelastic from the other side port and get your chamber stable. And then, try to identify if you actually went into a break. Now, the problem is that if you did have a break, then you're in a situation because right now you can't even go and, convert it into a rexis or something like that because there's no space over there.
No space.
Then it'll just be wishful thinking. So then you have to put in a good viscoelastic, maybe something like viscoat to plug that small gap till you can get, a better separation. So then you would have to proceed assuming that you have a PC break over there. And then without any major manipulations, hope to get one small chunk out so that you can have a better visualization of that area and deal with it. Most often you can get away with it if you don't have fluctuations in the chamber and make enough space for you to be able to see what's happening and replenish viscoelastic, push some viscoelastic, high quality, dispersive viscoelastic, which will stay over there and plug that gap. And you may be able to complete the surgery as well, but be prepared. And of course, an IOL scaffold, if you had a smaller piece, you could have, brought it out of the bag and put an IOL scaffold.
Absolutely.
Rohit, 1 minute.
Yeah, absolutely, yeah.
Rohit?
Yeah. David, your take on it?
Yeah, I think the first thing is you probably have to take over instead of the resident. But I would assume that you have a break. You may not. I think you can go ahead and either crack it or chop it. And if you can get it into heminuclei or quadrants, you can elevate them out of the bag so that as you try to remove it, you're not putting more pressure that would expand the possible rent. But
Yes,
the
and
minute you see vitreous, of course, you have to stop.
I would like to add one more thing in this thing is, because if it starts sinking, I think I want to mention David's name here. David Chang, Richard Packard, and Kelman brought out the PAL technique. So, if it starts sinking, I would suggest use the PAL technique to bring it up. If you're lucky, it comes out, no problem. But if it starts sinking, please use the technique which they brought out, and it's a fantastic technique.
So she continued, but she was oblivious of what she had done. Suddenly, she realized that something is wrong. Her hands are trembling, and she maintained what Dr. Gaurav said, stable chamber settings. And she sent an SOS, and I asked her to send the patient to me. So that done. So what next? Convert IOL scaffold or continue phacoemulsification? Well, the plan for me at that point of time was that in this patient, the CCC was intact. So I thought I'll use low IOP to my advantage. I would not do any rotation because rotation should not be done in such a situation. Implant IOL if possible or change to IOL scaffold if required, as has already been told. I would be using the low IOP phacoemulsification as has been shown by Bob Osher and Abhay Vasavra. So I would be, using IOP of around 20 or so. Max which I would be going on would be a supraphysiological, which I call IOP between 23 to 34 to my advantage. So the patient was shifted. I did separation, not extensive separation. Since hydrodissection had been done, it had been separated. I did exactly what David said, tried to pull it out, which I was able to because the adhesions in this grade 2 cataract were not that profound, did supracapsular emulsification in this moderately hard, not moderately hard, soft cataract, and the phacoemulsification was completed for one heminucleus. At this point of time, because of low infusion pressure, what was happening was the anterior hyaloid phase was not being broken, as has been shown by Abhay Vasavra, where high IOP, high fluidic pressure can break the anterior hyaloid phase. So everything was being done, and the posterior capsule was not being pushed behind, and the emulsification in this patient was eventually completed. Once that was done, I did what Dr. Gaurav said, that maintain stable chamber settings, because you do not want, with the collapse, with the chamber shallowing down, that the anterior hyaloid phase should break. So once that was done, the stable chamber settings, typically a bimanual should have been done, because you want to separate the different levels of irrigation and aspiration. I retracted the, the sleeve, and this is the Gills and the James P. Gills from Florida. His technique of dry aspiration is being done with a 25 gauge cannula. So that was done. Once that was done, then I thought of implanting. I could have rounded off the posterior capsular punch which was there, but instead I thought that I'll go ahead, and I did an optic capture, and the surgery was completed. So there's another learning in this patient. So this was a highly demanding patient who had a posterior polar cataract with pre-existing posterior capsular defect. He was highly demanding. There was a coexisting astigmatism, and the patient wanted toric intraocular lens. On anterior segment OCT, you can see there's a moth-eaten appearance. So it was almost conclusive that it is a pre-existing defect. The surgery was started. The surgery was started using low parameters, 28, but we usually come down to 28 or 30. And once at this stage, I realized that the rent was there. So stable chamber settings now. So what would you do? Would you, Dr. Kumar, at this point of time?
No, I think only thing different maybe I would have done is I would have done a femto in posterior polar where there's a pre-existing rent. Another thing is, many times when there's a pre-existing rent, the surrounding area is quite fibrous, so it's quite strong, so that actually gives you support. But this rent has happened during your last stages, so there's very little cortex remaining, so you can still plug that area, put viscoelastic on that, go ahead and do your bimanual IA, and you can put the lens again with an optic capture. So you can put it in, or reverse optic. But here reverse optic, because this looks like a linear tear. Yeah. So it'll be tough to put a lens horizontally because you can't put it vertically. Then I might put it in the sulcus horizontally and do an optic capture.
David? Yeah.
David, would you go ahead putting a toric IOL in this case?
And how much power of a toric does she need?
It was not the extreme height.
Yeah. So, I think if the toric isn't on axis, you haven't really accomplished anything. So I think you certainly can't argue with a monofocal 3-piece, and the sulcus, maybe do astigmatic keratotomy while you're there. In the United States, if you had a polar and you know in advance that the patient may have a PCR, we will tell them about the light adjustable lens where we can put that in and treat anything. And if you really needed like a T7 or a high power, you could do reverse optic capture.
Absolutely. So I just continued stable chamber settings, did IA, because once that was done, stable chamber settings again, because of the low IOP which I usually use, in these posterior polar cataracts, I give it a try whether I can pull the end of the tear back or not. I have gone through, created a small, incision at the side so that the chamber settings are stable, and I was able to round it off. So once I was able to round it off, I thought that I might as well try a toric lens in this situation, as David has taught you. You rotate it to the axis where you want to, and once you're around that, you just flex it in, mindful of the fact that you are behind the capsular axis margin, and push it in and flex it again and push it in. I was lucky this time because at times you really cannot. Had I not been able to do that, I would have done a reverse optic capture in that patient. So this is another situation wherein it is a posterior polar cataract. It's a very old movie. I'm going ahead doing my bit of sculpting, pushing the nucleus, which should not have been done. It's a very deep chamber, trying to create a situation where I would do cross chopping, and I crossed everything, the limits, and you will find that suddenly it has gone behind. So here, glued IOL and everything which Dr. Amar said would have been feasible, but I would like to show that what you can do to avoid such a situation. So why did this happen? Because there was over deepening of anterior chamber, there was pushing while sculpting, and there were wide separational forces. The high fluidics were the deterring factor which created a situation in which everything went topsy-turvy. So the plan is usually in our cases is that we use low fluidics, stable chamber settings to our advantage, appropriately sized incision, small rexes, no hydro procedure, no rotation of nucleus, and avoid separational forces. So now I would like you to see how, by using low IOP, we can befriend the anterior hyaloid phase. Here I'm trying to create an oval rexus as has been advocated by a very close friend of mine, Dr. Kiranjeet Singh, because that gives the advantage of both small and a large rexus, sculpting being continued, total division is what we aim for, and now the total the chopping is being done, and we have totally separated nuclear fragments, cross chopping as has been shown by Ronald Yaw, that is being done. So once you have totally separated it, that is the time when I'm pulling it out. Now with a small maneuver, after totally separating the nuclear fragment, now I'm trying to totally separate it. I'm doing the back flip, pulled it up, and I was able to emulsify, 1/2 of the nuclear fragment. So that's done. So back flip, whatever you want to call, you can do it, and that completes, 1/2 of nuclear emulsification. The IOP you will see has been further reduced to 20. So there is low infusion, no, pushing back of the posterior capsule, anterior hyaloid phase, the probability of which is remote, is very less. Now I would like you to focus on these three small nuclear fragments. With the stable chamber settings, the anterior hyaloid phase is acting as a friend. It is not acting as an enemy. So the nuclear fragments would be bouncing on the anterior hyaloid phase, and they would be coming back. So using these fluidics with stable chamber settings, you are able to transform the foe into a friend, and you will see while this is being done in a very guarded way, these three nuclear small fragments would not go back whatsoever. So the process is continuing, and this is the last piece, stable chamber settings. These three nuclear fragments are already there. So the Gill's technique of dry aspiration would be done by us. One of the nuclear fragment will come out, small nuclear fragment. What will remain are the two ones. And then, dry aspiration. Once that is done, so this is very handy. I've been using it, David Wright, since 1990, this Gill's Welch technique of dry aspiration. So this has really helped. So once that is done, so that nuclear fragment will not go behind because anterior hyaloid phase is taking care of it. The second is there, so these two pieces are now out. So this is, there are so many videos I have, but I think I'll ask Dr. David, would you like to take over? Yeah.